So this lecture is dedicated to my former middle school science class, as well as before I came here as an away student, I was heavily influenced by Dr. Selby, Dr. Garcia, Dr. Gore, Dr. Hassel, Morales, Khan, Kendall, Little, Kim, Willis, and Dr. Crafter. And then while I was here, really appreciate Nurse Chin, Nurse McFarland, Jahalal, Gia, all my PGY co-residents, so many others whose unique approach to treating trauma in the ED is a real special gem of this program. And then also dedicated to Mr. Chris Carter, Ms. Stephanie, Mr. Foley, Mr. Laguerre, Mr. Curry, Mr. Quintana, Mr. Curry. Special thanks to Mr. Lamont Dow, who's still searching for my long-lost family. And then every patient that initially cursed me out before I grew to love them, before they taught me how to expand my capacity to exhibit unconditional positive regard. And truly grateful to the entire program, especially, and all the staff on both sides of the street.
That was great.
Perfect. Okay, so when I was looking for what residency program to come to, I was really carried with me something from Georgetown that was called Cura Personalis. Is a Jesuit concept that meant you care for the whole person. And so when I was looking for a program, I'm trying to go to my next slide on this one.
Yeah, this is the one you have open here. You don't have to, you can go over here and open it from that one.
Is that one go right?
He opens that second one here, he just needs to open it.
Where?
Where's my go-to spots?
You know, during 9/11, you know who the.
This one over.
Oh, okay. Got it.
Yeah. There you go.
Yeah.
Okay, so in medical school, I was fond of a concept called Cura Personalis. It meant care for the whole person. So when I was looking for a residency program, and as an away student here, I really saw that exhibited by the attendings and residents here. And so I wanted to use a senior lecture to talk about another framework that we can use called trauma-informed care, and just more so talk about how we can keep in mind our specific population and our specific hospital. The trauma-informed care framework was actually a tenet of what CAVI brings to our patients, a tenet of their service. So just show of hands or pluses, who's heard of this framework? And more importantly for this lecture, who sat in a trauma-informed care training session? A couple of you guys, great. So when I was first researching this as a PGY1, CAVI had recommended maybe we could be trained as trauma-informed care providers. And so although it was in its infancy, there's still numerous implementation strategies. So looking at those implementation strategies, there are all sorts of roadmaps and core principles. And so for a brief moment, I kind of imagine you sit in a 6-hour training session, you hear about how to become trauma-informed, and you come out an expert. And so then, a roadmap like this would say we'd start out kind of assessing our triage and registration area, learning how to screen for patients with trauma, avoiding re-traumatizing those patients. And then at the end, we create clinical and organizational interventions to make this theory a reality, and then boom, we're trauma-informed care specialists. That's kind of how I pictured that training session to go. But in reality, trauma-informed care is just a framework, and any training session would just be kind of bringing you up to speed on what the core principles are, so that way we could implement in the hospital. But beyond any framework and beyond core principles is really something that we need to discuss and work out together. And it's clear that a lot of the implementation strategies have been geared towards pediatric ER and pediatric ERs at this time. But networks are growing and trauma-informed care is becoming more and more of a buzzword, especially in trauma centers like ours where violent trauma is an epidemic. And so all of these networks can kind of water down the importance of what we really do at the bedside and what we're trying to do for our patients. So in 2018, there was an Annals of Emergency Medicine article that highlighted why this is relevant to us in the ED. And they specifically said that trauma-informed care is a framework used to help us understand the context of each patient's life story. And providers can specifically use trauma-informed care to advocate for resources that address trauma in communities, such as hospital-based violence intervention programs. So that's what we already do here for physical trauma and for violent experiences that our patients experience when they first come in. So the CAVI violence interrupters, they're trained in trauma-informed care. They come to the bedside, they implement or they employ some of these strategies to help patients get through this experience. So we could sit in a trauma-informed care training session, memorize some de-escalation tactics and some core principles, and then come out better. But I think just like in many different jobs, I was a middle school science teacher prior to working in an ER, and we'd always have these professional development courses where you sit in all day long, you're talked to, and by the end of it, you're not sure exactly what happened. And so I would hope that a trauma-informed care training session would more so stimulate us to be able to hone our own skills as clinical monsters and further reduce harm and suffering, rather than just being a box to check off. And so just for the rest of this lecture, I wanted it to be more of like a dialogue. And here's a quote from a book that I read right at the beginning of residency that was helpful. It said, "Leaders who do not act dialogically, but insist on imposing their decisions, do not organize people. They manipulate them. They don't liberate, nor are they liberated. They oppress." From a book called The Pedagogy of the Oppressed by Paulo Freire. It's about teachers, and the book itself is actually about helping teachers reduce suffering in a community, or kind of help liberate any group of people, kind of relevant to us. So I wanted to kind of start out my own journey trying to assess trauma and trying to reduce suffering in a community. So prior to working in an ER, I worked in another setting that was similar to an emergency room, middle school science classroom. This was in Baltimore City. The school I taught at was called the Academy for College and Career Exploration. You can see these are some of the students who are doing basically like a greening project, getting the back of the school ready to kind of become a garden. And the demographics of the students were very different from the demographics of the surrounding community. And so the students who I had experienced trauma at home, they experienced trauma in school, and they experienced trauma on the way to and from school. So talking about one specific example that I think prepared me for some of my patient interactions was a story about a student named Antonia. Antonia was in my fourth period class, and my fourth period class came to me from lunch, just some context. So I had several class clowns, but Antonia was especially mischievous. Before the school year began, another teacher had notified me that she came from a broken home. And so I tried to kind of cater my teaching style to be mindful of her home situation. And so initially I showed favoritism, or I was avoidant, mostly. Those were the skill sets I employed. And I really was just trying to adjust to her situation. She continually pushed boundaries, disrupted other students' learning, and she would always be the last student to be focused on any group activity, especially trying to transition from lunch to fourth periods. One day she decided she was going to eat her oodles of noodles on the way back from lunch. She had a bowl and a spoon, and she was eating her oodles of noodles in the hallway. Our specific school is very serious about transitioning from lunch to fourth period. You are supposed to walk in a single line, second tile. And so she was deliberately disobeying this rule. After a bit of a power struggle, I confiscated the bowl of oodles and noodles and began walking back to the classroom. And before we could even start moving, Antonia notified me and the entire class that she expects to get the bowl back before we get to the classroom. In response, I threw the bowl in the trash can. She again addressed the entire class to let them know, my mother will handle you if I don't get my bowl back. And so, being a mature 22-year-old middle school science teacher, I marched back to the trash can and stomped one of my dress shoes on the bowl so it no longer could serve its function. No bowl to return home. The next day, she decided to skip her first period class to come disrupt my class. As I asked her to leave, she pulled out a very nicely well-made sandwich, chewing as I spoke. I figured this was just retribution for whatever happened in the day prior, so I confiscated the sandwich and the brown paper bag she was holding, and I threw it away. And tried to understand why she seemed so calm. I forgot about that sandwich until lunchtime, and 5 minutes into my lunch break, I was looking for my own lunch. I was starving, running around chasing 11-year-olds all morning, and could not find my meticulously made sandwich I had packed away that morning. Not until a student from my first period class walked by and asked me what I was doing, and I told them I was looking for my sandwich and my lunch, they started bursting out laughing. They reminded me that I had thrown away my own sandwich in front of the entire class in the first period, thinking that it was Antonia's sandwich. So for me, I had released anger and frustration at the acts of someone else who has experienced a whole lot of trauma, and neither of us gained anything. In fact, she lost the bowl and I lost the sandwich. So that experience really stuck with me. It was a humbling memory to reflect on before I started out as an ER resident. And so, your last year of medical school, you do your OSCEs, and or maybe the last second year you do an OSCE, and then your fourth year you do an OSCE. And we had a physician-patient communication course at Georgetown that kind of, as I reflected on my experience in Baltimore and my experience with trauma, I didn't feel totally prepared by those courses. So once again, in my wave rotation here, I saw multiple other physicians or attendings and residents that I was really impressed by. And so, so I'm really glad I came here to have the tools for harm reduction, and I would choose Kings County over if I had a choice. So PGY 1 year, I try to bring in my experiences from before and say, how do I bring in some of these, I guess now I'm learning that these are some trauma-informed care principles. How do I do better than I did before? So I wanted to talk about one patient my first year. I had a 41-year-old woman, history of major depressive disorder, not on meds, presented as a victim of sexual assault several hours prior, denies any complaints. She didn't provide any other history to me initially, and when the SART nurse arrived within earshot of the patient, told me that the patient's story just doesn't add up and believes the patient is not telling us the full truth. So I felt really awkward in that moment because I could see the patient looking at me, looking at the nurse, hearing that we don't trust her. And so I tried to go back in the room and try to take some of what I learned, and we'll get into some of the trauma-informed care principles, but try to take some of those, what I learned, back into that room. And so if I were to rewrite my HBI after seeing that patient, or after going back in the room, it might have, at least in my mind, if I rewrote it in my mind, not on the chart, but in my mind, I would say that the patient, using a different alias, Candace, using pronouns she, her, is a 41-year-old woman living in public housing with history of major depressive disorder, no established primary care, so no medication. She was sexually assaulted by a store owner that she reports had been verbally abusing her for months, and she presents in the exam room clutching a hardcover book called Certain People. The patient had notified me that they feared for their safety, but they specifically mentioned that they feared retaliation from both their assailant, but also the other residents who lived in her building. She had been reminded several times that she should not be calling the police for any reason. Any time she would call the police, she would face retribution herself. And so I spent maybe 5 more minutes than I did the last time. I got more information, and I was able to kind of give her the SART flow sheet so that way she understood what we expected. And the whole visit went was, for me, streamlined and went a lot better. And I looked up the book Certain People, and it was a book, it's specifically a book that, like, if you read the tagline, it says, you know, how the Black elite has left behind the struggling Black mainstream. And so I'm sitting there with this patient who I kind of understand a lot better, maybe the dynamic between myself and her and how she views me, just by thinking about the book that she's clutching and just by trying to be a little bit more interested and present in the room. Unfortunately, the next day, I was working on a string of nights, and the next day she came back as a, not a notification, but she came through ambulance triage after being assaulted back in her facility, or back in public housing. She had a normal head CT, and physiologically she had no significant trauma, but she did have a whole lot of trauma to unpack. Trauma with a capital T that she experienced the day before, that day when I saw her on the return visit. And so beyond her physiological trauma, and beyond maybe CAVI and violence interrupters, how can I, moving forward, be mindful of that, of all the trauma that she's experiencing? And what can the framework of trauma-informed care offer me during a conversation, maybe during reassessment, discharge instructions? How can the framework help me with my decision-making? And then also, how can it help me avoid re-traumatizing the patient? So we have to initially define trauma. I think, in the pre-hospital and triage setting, we hear like blunt versus penetrating trauma. And this definition is simple, but it gets a lot more complicated for us, even in the physiological realm. So there's trauma to all sorts of organ systems, and we delve into each. If you look at the DSM-5, they also have their own definition of trauma, a little bit more broad, but also shows that you can delve into different aspects of trauma. I won't belabor you with the definition. But trauma-informed care specifically uses the Substance Abuse and Mental Health Services Administration's definition of trauma, which I won't read this definition either. You can look it up, but more importantly, it's got it broadens the definition of trauma even further and includes things like childhood neglect, includes things not just mental health disorders and substance abuse disorders, but also having a family member with mental health or substance use disorders. And then violence in the community, poverty, systemic discrimination, and inequities. So I know I don't have to tell us as clinical monsters the impact of trauma on health. We know that people who experience trauma have an increased risk of chronic lung, heart, and liver disease, more likely to abuse alcohol, tobacco, illicit drugs. And we can cite articles and, once again, cite articles in these training sessions to prove the impact that we already know. But more importantly, we want to know, how can we become more trauma informed? How can we take that information at the bedside in our instructions to patients? And how does this fit into our specific practice? So one of the trauma-informed care networks created 6 core principles for healthcare settings specifically, what we can review to change our ED and make organizational and clinical interventions. So the first is safety. So how, throughout the organization, patients feel physically and psychologically safe. So when I reflect back on as a teacher, I'm pretty sure stomping someone's bowl does not make them feel safe. But on the flip side, in the future, as a PGY1, I do think that our ER at the time when Candace came to our ER, I did get the sense she felt physically safe. She felt safe from her assailant at the time while she was in the hospital. She felt safe from anybody else who would retaliate against her. Trustworthy and transparency. Didn't feel like I instilled a whole lot of trust in my middle school science classroom in that moment when I threw away someone else's food. And then also, I think the Candace in the patient example had some level of trust because we had gone back in the room, had really tried to level with her, but also some level of mistrust because it felt like she was being talked about without her consent, without her perspective. Peer support is another tenet of healthcare or trauma-informed care in a healthcare setting. So individuals who have shared experiences can be integrated into the organization and be integral to the delivery of the service. So what support did Antonia have inside the classroom? How could I have utilized some other students with similar experiences to help me, or maybe other staff? And then what support did Candace feel from her peers? Did she feel like I was her peer? Did she not feel like I was her peer? Something to reflect on. Next is collaboration, and I put choice in collaboration because, you know, a lot of trauma-informed care in a healthcare setting gets stuck, or I think some of the mishaps happen at choice. Mostly because it's difficult. We're the medical experts. This is, the emergency room is not customer or consumer-based, or it shouldn't be a consumer-based setting. It should be somewhere in which we provide a service and we have an expertise. But choice, I think, is still, and where it can be inserted is very important. So what choices did Candace have? I think this, once again, this things like the SART flow sheet that provide transparency also give patients a chance to kind of choose with us and make sure and have shared decision making to decide what to do. Empowerment is another tenet of or core strategy of trauma-informed care. And so, later I found out that many of the students in my classroom were illiterate. And so how do I make sure that I empower them to read? I fill in some of the gaps that they're missing so that way they can be empowered to get the most out of this experience. And then last but not least, humility and responsiveness. So not until I threw away that sandwich the next day did I really think about my own humility and my own responses and how that can really drive the whole environment in the classroom and in the ED. So for me, I know that I've come across a lot of roadblocks. Many days I thought there's no way that I'm going to be able to move forward, taking a new framework or a new mindset that could slow me down as a provider. But I have to remind myself that at the end of the day, I'm committed to human liberation. Here's another quote from from Pedagogy of the Oppressed. It says, the radical is committed to human liberation and does not become a prisoner in the circle of certainty, within which reality is also imprisoned. The more radical person or radical doctor is the more fully she or he enters into that reality, the more they can transform it. And so trying to enter in the reality of this is difficult. Being trauma-informed care and providing a trauma-informed care experience to patients is difficult. How do we try to get out of that certainty and of this not being something we can do, and how do we break it? So kind of going through these core principles again, I wanted to reflect. So in terms of safety, has anyone ever removed restraints on a previously agitated patient who you were worried about their safety? And then anyone immediately regretted removing those restraints right afterwards? Very difficult, very difficult. I think as an intern, I wanted to take everyone's restraints off, and as a second year, I wanted to put everyone in restraints. So I think, once again, something to think about. And at times, I do think removing restraints is the more safe option. At times, the less safe option. And so trying to be mindful of this and the trauma taking into perspective patient's trauma is important. In terms of trustworthy and transparency, anyone ever tried to be transparent about the fact that a patient's insurance company wouldn't like it if they ran unnecessary tests on them? Or just mention insurance companies at all the patients? Yeah. And once again, another thing that as a PGY1 I thought would be a great discussion. Patients would understand completely if I told them that this head CT was unnecessary and the insurance company wouldn't pay for it. And I immediately learned, maybe 2 or 3 patients into trying that was not helpful. So trying to think about ways in which we could kind of sharpen the framework. Peer support. Anyone ever tried to encourage a friendship between 17 hallway and 18 hallway?
No.
Sometimes it happens on their own. Anyone never able to finish their notes once that friendship is formed?
Yeah.
Another, once again, something to think about, but still, peer support is so integral. At times, the friendship between 17 and 18 is always the only reason you can get either of them to comply. Okay, choice and collaboration. I once asked the patient before I sedated them, I asked them, what do they need from me? I'm going to take away your autonomy. I'm going to put you to sleep. Is there anything I can do for you before we do this? And they said, there's only one thing they require. They said, can I please read the label on the medication in its entirety? They're scared and they just want to read it. And so I made the mistake of not drawing up the medication before I showed them the bottle. So it took me a very long time to actually get the bottle back and to deliver the medication. All PGY1 mistakes. Last but not, and then empowerment. We want to empower our patients. But has anyone ever asked a patient who's allergic to Tylenol, Motrin, naproxen, Toradol, gabapentin, Flexeril, lidocaine patches, what they preferred for pain? Oh, nice. But you kind of feel like a mind reader because you know exactly what medication is coming next. And so you want to empower your patients by taking into the complexity of what we experience in the ER. And then humility and responsiveness. I once worked in fast track, and there was a patient who's well known to our triage shower room who was requesting a shower. And there are only a few problems. Maintenance personnel refused to clean the shower because of a 10 by 5 centimeter log of stool that was left in the shower from the last person. When I notified the department head that they refused to clean the shower, the department head said they couldn't locate the maintenance personnel there anymore for the rest of the day. They had left for the day. And so I cleaned it up myself. I was so excited. I skipped back to the fast track. I went to tell the patient that I had cleaned the shower for them and they could take a shower, and they barked back at me that he didn't need a shower anymore. He demanded his discharge paperwork and berated me for taking too long. Lesson learned. So, and then just last week, I had this in, if Stacy is here, she knows the story. I had a patient who was on the ambulance ramp because several ambulances that had arrived at the same time at downstate. So I came out to meet the patient and just get a quick history. And she was under 40, young patient, but arrived with unilateral weakness. It was extremity, and it was upper and lower extremity weakness. But as I'm gathering a history, she starts shouting, I don't want to come one step further into this nasty ER. Don't bring me anywhere near all those bums and COVID patients. So I told her we would need to triage her in the ER, and she looked past me and said she wants to speak to a real doctor. At that moment, Dr. Siddert walked up, looked at her and said, discharge. EMS notified us that she had reported a brain mass in the past and she was status post surgery, and she had experienced the weakness before. So I decided to let the triage team troubleshoot getting her registered and ascertaining an initial history. But then I returned to the doctor's station. I told Stacy that I didn't have the best relationship with that patient, and that I already had some other patients that I had to go around and see. And then moments later, the triage nurse notified the doctor's station that the same patient was actively having a seizure. So all hands went back on deck. And I had several other similar interactions that day that made me kind of feel frustrated, and multiple times in residency, I felt frustrated at trying to be involved in our patients' healing, but also directly involved in their ongoing trauma that they're experiencing in the ER. And so I have to remind myself that these are just frameworks, and no one is going to understand the madness and what complicates our environment. But the patients are also caught up in the same madness. And in fact, they're the subjects of that madness. And the systemic injustices that are outside and inside our medical establishment that are beyond us are still things that they experience. And so I try to remember that my practice is truly and always about reduction of harm and suffering. And so I try to remind myself this sort of concept that, I talk about the people, but at times don't trust them. And trusting the people is an indispensable precondition for revolutionary change. A real humanist can be defined more by her trust in the people, which engages her in the struggle, than by 1,000 actions in their favor without that trust. And so I think the word trust in the people, or that part trusting the people, doesn't mean you believe everything that a patient says no matter what. And it doesn't mean that you show favoritism or you're avoidant. It means that you try to come with a framework that is intended to reduce harm and reduce suffering. And you as a doctor, or the Latin root of doctor is doctore, means to teach. So how do we teach, and how do we use our clinical skills to trust people, not necessarily just be avoidant or acquiescent? So next time, if you do end up in a trauma-informed care training session and you are kind of rolling your eyes and saying that they don't understand what we go through. They don't understand what actually happens. And each of these core principles can easily, you can easily poke holes in, because at times this is not so simple. Just remember that like most of our patients, they do come to us with this trauma. And so even if the framework or even if the core principles aren't are something that is not always, even if those core principles are not always applicable to you, remember that that our patients are still here experiencing that same trauma, and that there are things we can do to intervene. This study recently was put out in 2020. It's just a qualitative study, and they just interviewed 25 patients, but there were patients there was a trauma-informed care framework applied to them. And for the most part, they had, once again, just qualitative studies that had a positive experience. It's more interesting because they talked about where some of the mishaps were. And so patients who, as we know, patients who arrive with mental health conditions, patients who come with pain crises, those who are considered different, dressing different, living in poverty, maybe they're young parents. Those were some of the patients who felt like, even though the trauma-informed care framework was applied to them, they still felt like they were stigmatized or re-traumatized. And so it's important for us to try to employ this framework and try to see where maybe some patients are being missed. So as my residency education starts to wrap up, still trying to remind myself what it is about education that that excites me, why I got into academics in the first place. And so just leave you with this quote: education makes sense because women and men learn that through learning, they can make and remake themselves, because women and men are able to take responsibility for themselves as being capable of knowing that they know and knowing that they don't. And I've always been reminded throughout this every time I try to empower my patients or work towards safety or work towards giving them choice, I'm reminded that I need to make and remake myself. And those frameworks and those core principles are things that that take time. So I know I'll be taking with me all the lessons that I learned from residents, attendings, nurses, techs, staff, especially my PGY core class. And I'll strive to be a more trauma-informed PR physician. And I'll carry all the lessons I learned from you guys, and I'll always be highly appreciative of this entire body of physicians. And hope one day to come back after this COVID regime is over. Thank you. Questions?
Do you have a course that you liked? It sounds like you didn't love any of the courses, and is there something you recommend that you felt was really papers or courses?
For trauma-informed care?
Yeah.
So there's like one thing that I really enjoyed that I did with some medical students was a trauma-informed care questionnaire, where basically you walk through being a patient from door to dispo, and you try to think about all the things that could re-traumatize you given your own experience from door to dispo. And I think that's the best way to do this. There's no general framework that can teach you how to deal with something that's so complicated. I think you have to go step by step. And in that study that the qualitative study, most of where the patients felt like they were re-traumatized was in triage and registration. And once triage and registration is just something that we kind of think of as just one piece of what has to happen in the ED, and there's no trauma-informed care approach to it. But I think there is, and I think this is something that us as doctors shouldn't just be trained in, but we should do collaboratively with people at the front, registration, even outside, even in the pre-hospital setting, maybe with EMS.
So sort of on that note, it definitely takes individual participation to make this happen, but also at the systems level. I'm sure you thought about this. So what change, what specific change would you recommend or advocate, to go down this path?
Yeah, I mean, I like that one quote where they said, we don't impose, leadership doesn't impose from on high necessarily. It's a discussion together. I imagine that I can't imagine one change or one intervention or organizational intervention that would fix any of these problems.
Sure, but what change that might be, the first change, as you've seen in the last few years here, right? What's one step in the right direction, if you had to say one thing?
One thing.
I'm curious, what are,
I mean,
I'm
I
not putting
think,
a spot, but,
I think
Not to put you on the spot as I put you on the spot.
I think between choice and transparent, like, there's man, I'm not gonna remember the name of the bill, but there's something called like the final rule or the final decision on healthcare interoperability. There's like something that was added into the last, one of the COVID relief bills that says that we have to kind of provide full transparency. We have to print out almost, all of a patient's chart and give it to them, and they should have access to that, or access to a patient portal. And so, when I heard about that, I was like, wow, that's important. That's big. That's huge. That's part of like a trauma-informed care approach in which you're providing that level of transparency for patients. Now, on the flip side, now patients have all this information and they're like, why is my, MCV 77? You're like, okay, I can explain that. And then they're like, why is my MCHC some other number? You're like, okay, I can't. This is too much. It's too much. And so I think that level of transparency is huge, and I think one of the big steps. But I know that it's like everything else, something that we need to maybe delve into the nuance of how this can be helpful to patients.
It's transparency. It's also empowering the patient.
And empowering, they then take that information and then look things up on their own, seek other doctors, and
Or
Have you
challenge
had-
what you said.
Have you had people do that in the ED? Because I've had a lot of them recently.
what's that? Ask for all their paperwork.
Currently, because of the bill, because it wasn't the last one, I think it was a couple before.
Right.
So now at county, they have access to the patient portal, and I thought it updated after the visit, but they have access to their data in real time.
Right.
So I've had people get they come in for pain after something, you send all of these tests, and they're getting the results sometimes as you're getting it, and you walk into the room and you're like, doc, I have cancer because I saw that you sent a
Wow.
CK and I looked it up and this is what it means, and you're like, whoa.
Exactly.
Or my beta HCG says it's less than 5, but it's not 0. What does that
Am I
mean?
pregnant? Right.
Yeah, and it's a very interesting thing because I think it's a good thing for the patient, but I think with a lot of these things, opening it up without providing access to care isn't just numbers and the printouts. Care is the education and the back and forth, and the ED is not necessarily the place for it. So opening it up without true access to care, I think, is problematic.
Exactly. It's something I'm sure we're all going to experience moving forward.
Yeah.
It's
been very interesting.
And we know that transparency is important for patients. And so we know that, and we're hearing that things like trauma-informed care are buzzwords, and they're coming in, and people are going to, I'm sure it's going to be part of being a level 1 trauma center. You got to have some sort of approach. And that's why it's important for us to be involved in that discussion and us to kind of think through these things so that way we can see what, potential mishaps moving forward could become barriers.
Thanks, sir. Great job.